He took around 2 hours of fields class to our VOA. We conducted one session once in Park Hotel and then another time in some other place. Regional eye hospital also he addressed. Yeah, hands-on training in gonioscopy and all. He participated in one of the workshops. So he's a great teacher and then taskmaster. He is a taskmaster. So we really lost two great people. Yeah, I think it will be an irreparable loss, irreplaceable loss to all of us. So now we'll start the actual program. I think they're almost finishing the lunch. So first we will invite him, we'll introduce the Nato Rosatelli. He is one of the world famous phacosurgeon, fastest phacosurgeon, highest volume phacosurgeon. There are many things. He does around 230 or 240 phacos per day. On average, around 60 to 70 phacos per day. So it's a great opportunity for all of us. After the program, those who want to take pictures with him, please don't lose this opportunity. You can preserve this in your lifetime, and it's a very rare opportunity. I was with him yesterday, last 2 days. There's a wonderful collection of videos. That's the reason we took extra effort to put this LED screen so that we all can enjoy. So I know the other side you have a bigger distraction, but I think we will definitely complete this. You can have your own choices later on. After the session, please feel free to ask questions. Any doubt? He is also a great teacher. Don't hesitate. Don't think that such a renowned person, he may not. Madhu, can you ask Madhu? Madhu, can you ask Sunil to come? So by the way, say next, we are completing our term before he comes.
So the VOA association has completed its tenure more than 2 years because we have taken a lot of time because of the in between this COVID issue. So we would like to announce the elections for the coming general body meeting. And meanwhile, we are establishing an election committee with certain senior and professors to guide the instructions. And those who are interested can place their nominations. And there are some criteria already been incorporated as per the constitution. One post has gone to REH and another, something like that. So meanwhile, prepare yourself. Those who are interested can contest in the elections. And please try to get ready with your nominations.
We'll be sending the circular. Those who are interested to serve, please come forward, take the burden of running the society, and then take the society to the next heights, greater heights. And definitely, we should conduct regular meetings. The aim is regular CME meetings, minimum once in 2 months. And then if there is once in one every month, even that also is fine. Minimum once in 2 months. So there should be a good interactive. We'll bring the foreign outside speakers and local also. We have an excellent talent now. And also we'll conduct a lot of PG training programs. And also we'll take the help of the APOS, AOS, and also we'll conduct the PG training programs. So the main aim of this society is the medical education, continuing medical education. Sunil, now we will proceed. Now I request Sunil to hand start the academic session. Okay.
Is this on? Yeah. So, good evening or good afternoon, everybody. I normally don't dress like this, okay? This was given to me by NATO as a gift. And this is the, here. And NATO, I was just talking about your T-shirt. So these are the original colors of the Brazilian football team. And I know this is the last time I can wear it because the moment my son sees it, it's gone. So that's why I came in these colors. Anyway, it's a pleasure to, have NATO with us. And it happened by, can you connect the laptop, please? Shall we connect it here? Mm.
Yeah, you can keep going. We should see if it's okay, but it's already connected.
No.
No need. Only you want me to start that?
No, I will introduce you, and then you can introduce yourself.
Okay.
Yeah.
This one. No, the other one. So I think you should say. Yeah. Okay. It's
Should I
ready
put it
to
on?
start. Can I put it on?
Yeah.
Okay.
Yeah. And I called up NATO and I said, see, you're free on the last day. So please, you have a lot of fans here. So he immediately agreed. And Gopal, Madhu, they made all the arrangements, fantastic arrangements, I think they've made for both NATO. And I'm just going to tell my part. I'm not going to talk about what all. I've been to Brazil. Before that, please, can I invite NATO to, NATO, can you sit on the dais there, please? Who else is sitting there? That's all. Yeah. So, as I'm sure most of you are following, is there a brocade or something? I am very bad at protocol. Please, I am horrible at protocol. Yeah, please, NATO, please accept that. So what I can say, my introduction of NATO, you know the videos on YouTube and all the forums that you're watching, but I have seen, I've been in May at NATO's place. It is amazing. And I can go on talking about NATO. So you know about him. I'm not going to go on like that. But the most important thing of NATO is Agda. She is the one behind everything. If you go to the theater, without Agda, nothing can run. Absolutely. She sets up the patients. She chooses the patients which are tough, which are easy, well dilated. NATO can get very angry at times. Don't underestimate this simple man who smiles all the time. He can get angry. So she is the one who keeps him calm, cool, collected, and that's why he can do 100, 200 phaco's a day. It's not a joke. And he does it so well. And it's not about the number. Please, people think, oh, he's doing this many number of cases. It's not about the number. It is the quality at which he does it. It is right up there. It's right up there. And that is the beauty of his thing. And if you actually go to his setup, you'll understand why it happens. NATO, of course, Agda, and the team. Amazing team. It's an amazing team. And I think they've been with you for 12 years?
I'm sorry?
They have been with you for 12 years? 12 years?
12 years, yeah,
most of them.
Years, yeah.
And so it's just fantastic. So with that, and he has brought a lot of innovative techniques and all. I'm not going to go into all of that, but I just want to give them a warm welcome, both NATO and Agda, to Visakhapatnam. I'm so happy that they could make it here. And with that, I think, we can go to the session, and NATO, you can start off.
Thank you, my dear. Thank you, Sunil, for the kind words. It's a great honor for me to be here. And I apologize for keeping you away from the great game that is, I think, just starting right now. So it's, again, I'm very happy to be here with you, sharing experience, and I'm sure I'll be learning a lot too. So. And okay, I will start talking. I think this is the most important thing I'll talk about is how to enhance your surgical performance. And that's why I put it in the first place. Afterward, I'll show some aspects of our high-volume cataract surgery work and also some techniques that you must have seen on the channel. What is the meaning of high-performance cataract surgery anyway? No, it's not that. It's not speeding. High-performance surgery means excellence in surgical technique and, yes, efficiency in both surgical time and material use. All this to achieve the best surgical outcome for the patient. What are my thoughts on cataract surgery? I think it is something extremely personal, meaning that each surgeon has an almost unique way of operating, from handling the instruments to approaching a particular case. This is why it might be reproducible between different surgeons, or definitely not in some cases. It can be said that there are as many phaco techniques as there are surgeons, meaning that each surgeon has a personal one, which can be an adaptation from existing techniques or a completely new one. It becomes clear then that there is no best phaco technique. That's something very personal for each surgeon. By refining techniques and achieving proficiency in surgery, the surgeon can achieve what can be defined as art, in the sense that it is the expression or application of human creative skill and imagination. Still, not only in a visual form, as art is commonly defined, but also in a functional way. Over time, patient expectation of cataract surgery has grown increasingly, and surgeons must keep up with that. So first of all, how can you improve your surgical technique? What I'm about to say now is essential to achieve that. These three things. First one, deliberate practice. This means performing each surgical step deliberately with care and attention to proper technique and standards every time. Work in a consistent environment, having everything you need at your disposal. Perform immediately result evaluation to check that what you're providing is giving a good result for the patient. This is a well-worn concept, but it is an absolute truth. Phaco surgery is absolutely step-dependent. The poor execution of a surgical step can compromise the rest of the surgery. Of course, it is difficult for a novice surgeon to practice this, but it mostly depends on attention, determination, and knowledge. The surgeon must keep in mind all the theoretical technical aspects and the requirements for the successful execution of that surgical step, and stick to them at all times. Good surgery requires control of the processes and maneuvers involved. Effectiveness, efficiency, and safety depend on that. Therefore, only proceed if you have control of the intra or extra operative situation. Avoid performing the surgical step with no control just by doing it and getting rid of it soon and moving on to the next step. This is a big mistake. An imperfect incision has incisional leakage and will cause a surge during nucleus emulsification. A small rhexis may cause a radial tear when handling a harder nucleus. The effort in perfect execution is what promotes improvement. Practicing a movement the wrong way will teach you to do it wrong every time. Practice makes an act permanent in its execution. So always perform it perfectly and correctly. Don't worry about the subsequent steps of the surgery. They will come later and depend on the step you are doing now. So concentrate on it and take your time. Time pressure is usually the main factor that makes a surgical step poorly performed. Contrary to popular belief, the perfect surgical step always saves time. The surgeon must have an efficient team to help. Sunil has just talked about that in my practice. Leading by example is the way to go. Task given should be equal to task done. My OR team rotates everyone's positions frequently. In this way, everyone knows how to work in every OR position. Team pride, confidence, and companionship ensure happiness and effectiveness. My surgical team is my family. Without them, I am nothing. Optimizing surgery performance is the easiest and fastest way for the surgeon to improve it. What does that mean? It means eliminating or reducing as much time as possible between the surgical steps, or idle time, which is time wasted. As we will see, this brings both gains in time and other important advantages. Perfectly trained assistants or trained scrub nurses are essential. The assistant must know exactly what is happening in the surgery, what instrument or device the surgeon will need at every moment, and how to hand it over to the surgeon and to receive it. This allows the surgeon to focus exclusively on the surgery, not on the surgical table, wasting time looking for and preparing instruments. The organized surgical tables allows the notion of where each instrument is, streamlining the process and providing safety. Everything needs to be ready before operating. Surgical material, consumables used, the lens to be used, etc. It is important to anticipate possible difficulties in the case, review the history and examination data, and as much as possible. This to prepare for different surgical scenarios you might encounter as much as possible, diminishing decision-making situations. This enforces a consistent approach during surgery, allowing for better technique evaluation. This is better for your team too, which will know how to act. Reducing surgical time provides several associated advantages. It allows greater concentration, focus, and attention of the surgeon in the surgery. Reduced surgical time is beneficial for the eye. Lengthy surgery causes greater trauma, inflammation, risk of infection, etc. Finally, faster surgery has lower costs for the operating room and the surgeon. If you can operate on 10 patients in one morning, instead of spending 2 mornings on it, you gain free time to do your other activities, and your your time is quite expensive. The greater productivity of the OR is very welcome, especially when you are operating in an OR that is not yours. You will be seen and treated as a special partner and not as someone who takes up a room all morning to do 2 surgeries and gets in the way of the whole schedule. Recording, reviewing, and studying your surgery significantly accelerate the surgeon's progress. Get used to making it a routine. Don't worry about creating a sophisticated, high-quality recording system now. A simple and inexpensive system is sufficient for this purpose. And today we have many options, including smartphone recording, etc. Recording provides the opportunity to identify errors in technique in situations where the surgeon systematically has difficulties to correct them. And one can observe where time is wasted unnecessarily during surgery, identify the cause of surgical complications, determine what went wrong, and learn from your complications. In reviewing his or her surgeries, the surgeon will see things he cannot see while operating because attention is focused on what is being done and he cannot see the rest. Show your surgeries to experienced surgeons. Ask them to comment on their mistakes and successes and consider the suggestions for improvement. Today, we have access to a plethora of techniques, tips, and information shared by numerous exceptional surgeons on the internet, which we can learn from. Observing a technique being performed correctly helps in improvement and understanding. We are very efficient at learning through observation and imitation. As we learn and progress, we can see details in the techniques that we didn't notice before. So always come back to the videos to study. Do active observation. Watching a more experienced surgeon do what you couldn't. Take the opportunity to learn from the complications of other surgeons. If I had only one tip to give novice surgeons, it would be to always ensure the best pupil dilation possible. Meiosis is an unnecessary complicating factor. The surgeon already has a whole series of difficulties with the techniques, device, microscope, and patient. Obviously, there is no need for another. Insufficient dilation is almost always the result of poor preparation. In my daily practice, attention to adequate dilation is absolute, saving me from many problems. Always keep improving your surgical technique, regardless of your skill level and experience. Build and cherish your team. This is the key that allows you to go to another level of surgical skill, definitely. You can't afford to be cheap. Quality surgical instruments and equipment always pay off on the long run. The way to surgical excellence, speed, and efficiency is perfection in execution, not hurry. Of course, the right mindset is essential. Never be satisfied with your abilities. Have the humility to see your limits and be able to improve. Thank you for your attention.
You go on to the next one.
Okay. Can I alternate a little of the subject? Because I have something to show about my practice, but I would like to show something about the technique before, so that it gets more varied. Okay. Okay.
Yeah, I thought you started in a right way, like how one should start practicing the surgical technique, how to improve, what are the basic things. Now they are very clear that you can't deviate from the basics. Suddenly you can't become a great surgeon. So you have to build from the scratch by observing and other things. There are a lot of postgraduates are here. So what would you advise them when before starting straight away on to the human eye? Did you suggest any process for them?
Oh yes. Okay. I graduated 35 years ago, and at that time we didn't have much option than to start operating in the human eye. Sometimes we would surgery to practice in pig's eye, but pig's eye is much more difficult. I don't think it's a good, let's say, learning tool for us. But nowadays we have many simulators. Yes, many ways to improve and to learn surgery before going into the human eye. And yesterday I was at the CCC in Hyderabad, and I had the opportunity to experiment a little on the Help Me See simulator, and I was amazed because I really think this is a wonderful tool to prepare the novice surgeon how to, let's say, how to do all the surgical steps, how to think the way the surgery works, how to understand all the processes, the way to do things before going into the human eye. Because I had the opportunity to teach surgery for a long time, and I could notice that the most difficulty the novice surgeon had was not knowing how to perform each surgical step. And the simulator helps a lot on that. Of course, it is a little different from the human eye, but it's nowadays it's like a very similar way to do things, to move your hand, to move your instruments, so I think it's a wonderful tool. Of course, the surgeon must be, let's say, keep up, must study all the surgical steps and understand them. And as I said on the last slide I showed, not be satisfied with his or her current skill level. You must always, let's say, aim to get better, to learn more, to perform different techniques, to be able to be a better surgeon and to provide your patient a much better surgical quality.
Before we go to the next talk, any questions from the audience regarding the first talk? We have a few online questions which I'll put to Neto.
Okay.
Yeah. Any questions from the audience, please? Okay, we'll start with the online.
Maybe you can type in that VOA group, so we will access and then we will see that.
Yeah, you type it in the VOA group. That'll be better. Type your questions in the
See,
VOA
like
group.
he stressed the importance of first, you should thoroughly read about the steps of the surgical steps, and then assist the senior surgeon, and then watch all his maneuvers and movements, and then learn from some of his challenging cases, dealing and all. So these are the most important thing. Once if you start, the most important point is highlighted. Don't waste time. In some of the steps, initially we take really 1 hour to complete a surgery. So that is fine for the first case. So your next target in next case, you should cut down the time. You should go back and watch your video and then see where you can cut down your time. See, sometimes you may be just doing the same thing, holding the conjunctiva 2 times, 3 times, without correcting your correct technique of holding it. So that these are the finer points I think you can improve on yourself, or you can have a mentor or a teacher who can sit by the side of you and then guide. Is that right, Neto?
Yeah. Completely agree. That's the most important things.
Yeah. Neto, there's one question. I mean, there are lots of questions, but I'll put some of them. How do you manage attrition in your surgical team?
I'm sorry?
How do you manage attrition of your staff in your, of your surgical team?
Yes, let's say we've been together for such a long time. Yeah. We're really like a family. And of course, there are some problems, but the important thing is when we are, this is, let's say, view or taken in a professional way.
Yeah.
Sometimes, of course, there are some aggression between them, but they know that this is to get the, let's say, all the work better. It's not a personal, so they know how not to take it personal. It's very rare for us to have something like that because we are like brothers, and I am proud to say that the team is, let's say, very, very proud of what they do. They know it's a wonderful quality what they're providing for the patient, and this is in their mind. So they like when Agda, for example, tells them, no, don't do it like that, do it like that. They know they are learning. They are going to improve. That's the way they must think, so that there is no problem about that. So this is really a minor problem in our team.
Yeah, of course, sometimes attrition is good for everyone,
Yeah.
including for the team. See,
Yeah.
you see, they may go to next level and they can have an independent one. Then once there is an attrition, the junior level can scale up to the next level.
Yeah,
And there are a
yeah,
lot of
sure.
advantages for the attrition. Let us
Yes.
use the attrition to your advantage.
Yes, yes.
There was a study actually done long ago, and many people think it's the pay that matters. I don't think so. Of course, you don't pay them less. You pay them, and NATO pays them very well. So you pay them well, but the appreciation that you give,
Yeah.
that is the most important thing. You have to appreciate their work, and not just take it as something that they just have to do. So that's this thing. Okay, the next question: after how many surgeries do you take a break? I know you don't. And what do you do in this break?
Okay, we usually, let's say, my usual surgery day now, okay, I do about 100 to 120 surgeries a day. I start operating about 8 or 8:30 a.m. That's late, but in most places I operate to receive the patient. They are screened, they perform examinations, they are prepared for surgery, so it's very difficult to be able to do all that and start surgery before. In some, let's say, we have 3 clinics around Brazil, I will show. In these clinics, we are able to start earlier because the patients have all they are screened, they examined, and prepared, let's say, all the ophthalmological examination is done before. So we can start earlier. If not, the patient would need to come to our clinic like at least 4 a.m., which it sometimes happen. I will show in which occasions it is like that. But I start operating like that, usually at about like 20, after 20 surgeries or so, I take a break. But it's like a break to let's say, stand up a little, go to the washroom and come back. And then we have lunch usually between 11:30 or at most noon, about 1 hour break, and then we return. Then we take another break like around 2:30, and usually another break like 4:30. We usually end our day between 5:30 p.m. to 6 p.m. So that's how we work. My team we don't like, neither me or my team, we don't like longer breaks because let's say, we lose focus.
Yes.
That's it. So they usually, sometimes I ask them, do you want to take a break? Say, no, doctor, let's go straight. We are very used to work long hours, so it's nothing for us. But, well, I'm 60 years old, I have to take a break sometimes. So, but they are young. They are almost all of them are under 30 years of age, so they can, they withstand much more than me. Usually, it's Agda or them. They say, doctor, it's time for you to take a break. Because I don't notice, because I'm so focused on the surgery, I don't realize that I need to get up, I need to drink water, and something like that. Yeah. Okay, we do like that. I operate we have a clinic in São José dos Campos, which is a city near São Paulo, 100 kilometers. I live in Ribeirão Preto, which is a city in the northern part of the state of São Paulo, 300 kilometers away. And my team lives in most of my whole surgical team. We have local staff in everywhere we operate. But I have, like say, my inside OR team travels with me. And they come from the state of Bahia, which is like 1,300 kilometers from my city. So when we start like a surgical run, they come, they pick me and Agda at Ribeirão Preto. We go to São José dos Campos and start. I usually operate like 600 surgeries in São José dos Campos for like 5 or 6 days. Then we go to the state of Santa Catarina, where we operate on 5 or 6 cities, usually like 3 to 5 days in each city straight. So regardless of if it's Sunday or a holiday, we do it, we work without stop. We have long, these cities are usually very far away from each other. Sometimes we have like 18 hours, an 18 hours road trip between cities. So when you travel, we have the next day off, and then we work for 5 or 6 days, and it goes on. We usually stay away from home from 40, sometimes to even more, but 40 to 50 days straight. It's not easy. It's one thing to perform 100 surgery one day. To perform that day after day, 40 days, not easy. But we are used to, and all the, like say, the setup we do, the protocols we follow, the way we organize our work helps a lot to be able to do it without, let's say, being too tired and being. In fact, it's a very, let's say, inside the OR room, Sunil had the opportunity to see, it's a very happy environment, calm but happy, so tranquil. We wouldn't say that we would perform 100 surgeries at that in this way, because it's so no hurry. So
actually, it's a very relaxed atmosphere in his theater.
Yeah, Neto,
In
sometimes, sometimes the number of cases in your list and the time limit, maybe like 2 o'clock, you have to catch a flight. So sometimes they put a lot of pressure on you. How to cope up that?
Oh, okay. We only travel by, we have we travel like a convoy. We have a big truck with all our equipment and consumables, everything, and 2 or 3 vans. So we go at the time, I have absolutely no time constraint. I determine when we start, when we finish, up to what time we are going to work. And so this is no problem. And the places where I operate completely, like say, respect that. So this is not no problem. For us, it's not feasible to go by plane. Of course, I could go with Agda, but we have an enormous team, and if I was to estimate, I think we carry easily more than 10 tons of equipment, including everything, because when you are going to operate on a hospital, they take out everything. There on the room, the OT, and we fill with our equipment, microscope, the Ingenuity, phaco, the backup equipment, everything. So it's a huge amount of equipment and the load, I don't know, that we carry. Yeah, so it has to be by road. Yeah.
Yeah, I was just telling you, but it's a very relaxed atmosphere, really relaxed. You have to see it to believe it. In fact, I was the only one who got tired. I was standing there, and I was getting tired, but the others were totally relaxed. Okay, Neto, I think you can go on to the next topic.
Okay, okay. Yeah? Okay. I think I'll talk a little about technique and show some videos so you don't get so too sleepy, yeah? And I will start with the nucleus spin, which is the technique that I think I am most known for, and maybe it attracts the most interest in you. I think this is the one technique that you can easily achieve experience and perform it. What is the nucleus spin? It is a fast and repetitive nucleus rotation. That's why I named it the spin, in both clockwise and counterclockwise directions. The spin is performed after hydrodissection, but it is not that small and simple nucleus rotation intended only to free the nucleus. The purpose of the spin is cortex release, achieved because the nucleus rotations drag the epinucleus and cortex along, detaching them from the capsular bag. But why cortex release? Why is it important? Cortex management is an essential surgical step. It is time-consuming, including the need to switch instruments. Cortex removal can present difficulties. Subincisional, equatorial, and posterior capsular adherent cortex can be challenging to address. Intraoperative meiosis can hamper cortex visualization, making its removal troublesome. Most importantly, it has been shown that most posterior capsular rents happen during cortex management. It is clear then that it would be extremely beneficial to facilitate or eliminate this surgical step. Two maneuvers can help it. One is the well-known and universally used cortical cleaving hydrodissection, but it often is not enough to achieve that. In conjunction with the nucleus super or over rotation, the spin, complete cortex release is achieved in most cases. The spin technique is really simple. It should be performed right after hydrodissection with or without hydrodelineation, under irrigation by the fecal probe or under OVD, using an instrument like the chopper itself or a Sinskey hook. For example, the spin maneuver can be performed in fecal and manual small incision cataract surgery. Let's watch the technique. Right after hydrodissection, I free the nucleus with small back and forth movements using the long chopper. Then multiple clockwise and counterclockwise rotations are performed, 10 times in each direction here, as this helps by removing lens equatorial epithelial cells also. And the carousel technique was used. No cortex or epinucleus remains. This is what I now call the simple spin. But about 2 years ago, I started to evolve the spin to achieve even better cortex release, incorporating a technique I developed for posterior polar cataracts, the mechanical cortical cleaving, which is the mechanical detachment of the cortex from the capsular bag, performed by sweeping a long blunt chopper along the lens equator. In this way, the sweep and spin technique was created. I first perform a mechanical cortical cleaving on 100 and then continue in the same movement by doing the regular nucleus spin rotations. And so what are the advantages of the sweep and spin over the regular spin? The sweep maneuver promptly and effectively detaches all cortex from the bag in at least 180 degrees. The already separated cortex is dragged along, helping to detach the remaining cortex. As cortex detachment is more effective, fewer nucleus rotations are needed. It is even faster than the regular spin. And now the sweep and spin. Gentle hydrodissection is performed. Then, before nucleus rotation, the long blunt chopper traverses the lens equator opposite its entry side, separating the cortex from the capsule and dragging it along. Nucleus rotations begin, and now all cortex is detached and carried with the nucleus. Only a few nucleus rotations are necessary with this technique variation. Nucleus management is then routinely performed, and no cortex is left upon completion. Any technique can be used after the spin. And as you see, in most cases, no cortex is left, really making it easier. So, oh, I'm sorry. I jumped. Sorry about that. Let me try to get it. Yeah. Oh, I'm not being able to, but that's okay. I show it one variation. Let's go for it. I don't know if you were able to get the difference between them. This is an important difference, and really with the sweep and spin, the effectiveness of the maneuver is greatly improved. But I'll talk about the one disadvantage. So with the simple spin, it's just rotation. You can, let's say, put any instrument. For beginners, I would recommend a simple Sinskey hook and do the rotations. Okay, the speed in which you perform the rotations isn't really important. The important thing is that you keep rotating and making an as round movement as possible. This is the best way. The sweep and spin goes mechanically detaching the cortex in, let's say, half around the lens equator. And then this is enough to allow detachment of the whole cortex afterward when you begin the nucleus rotations. And because of that, you don't need to perform like 10 rotations in each direction as you should on the regular spin. Sometimes 2 or 3 rotations are necessary. And the surgeon can really feel when the friction suddenly disappears. You say, oh, I know now that no cortex all cortex is detached because it offers no resistance to the nucleus rotations. So in conclusion, both techniques were developed to enhance cortex release, conferring safety and abbreviated surgical time. The spin is straightforward to learn and execute. I recommend surgeons to master this technique before moving to the sweep and spin, which is more effective but much more challenging to master. The sweep and spin requires a long chopper of 2 to 2.5 millimeters in length for maximum effectiveness. The simple spin does not. One can slowly build the skills required to perform the spin and the sweep and spin and safety.
The two modifications which I have noticed, one is the ball, the tip became a ball, that modification of the hook.
Yes, this chopper, right after when I started doing phaco in 1994, I started performing the Dodic pre-chopping technique, in which you use two similar chopper, 2 millimeters in length with a little ballpoint. That's the pre-slice technique. But and then I got used to use this kind of chopper, and when I developed the spin, I preferred, and there's another technique that I'll show, which is the wet mechanical chopping. I saw that in harder nuclei, I would need a slightly longer chopper. Then I modified the chopper to have a 2.5 millimeter bent portion. It has a very thin neck. The bent portion is very thin. So in this way, it does not require a cutting edge. It cuts in every direction. And it has a 0.5 or 0.5 millimeter ballpoint. That's the way the chopper is. It's a simple instrument, in fact.
The another point I noticed is you're keeping the bevel down. The phaco needle tip, the bevel, you are keeping it down.
No. I usually keep, when most of my surgeries I do the wet chopping. I'm going to show now. It's in niche. I use the bevel sideways. Okay, all the time. So in that I turn the sleeve parts to be like on the horizontal plane. So in this way they wouldn't irrigate the endothelium, for example. But the surgeon can perform it while let's say with irrigation on and doing the spin. So it really has is possible with that with the spin to perform any phaco technique afterward. It's it's really easily incorporated. I'd like to show the last slide. I accidentally pressed the
last slide, please.
yeah.
The last slide.
Yeah, that change in the direction of the bevel, I think it is creating that carousel effect more effectively than a bevel up.
With the bevel sideways.
Yeah.
Well, that may be a particularity of the machine I use. I use the Constellation machine. All Alcon machines are the same in respect of that. I have longitudinal ultrasound and also torsional ultrasound.
Centurion.
And when you use torsional ultrasound, it is more effective if you maintain the bevel sideways, because when you apply ultrasound, the nucleus pieces tend to rotate in a plane perpendicular to the bevel. So if your bevel is like that, the pieces rotate like that, which is much better for followability. You have more space, and if you maintain your phaco tip like bevel down or bevel up, they would rotate upwards and downwards, so you have less control. That's why I use it like
Yeah, if you can show that video, I think we can appreciate that.
Oh, yes. Well, just finishing, the spin is easily incorporated in the surgical routine. It is very zonular friendly, and the forces are applied tangentially to the entire zonular apparatus simultaneously. It would be logical to speculate that a maneuver friction removes lens equatorial epithelial cells, diminishing the posterior capsular opacification rate. It diminishes or eliminates the cortex management step. That is why I developed it, saving time and providing safety. It is a usual additional to your phaco or SICS surgery. And I think on the next video I'll show, which is the wedge mechanical cortical clavia, the aspect of the phaco tip is clearly visible, okay?
And NATO, about the carousel technique,
Yeah.
you can do it with the other machines also. You do it.
Yes.
But
yeah.
it is, in my opinion, when you get it, it looks like a song. It looks beautiful, but it's not always repeatable.
Yeah, it's very difficult. It's not
not very
reproducible. It's very, like I say, it's very satisfying to perform when it works. But it's like I could say safely that 1 out of 5 or even less comes out like that. You saw that it rotates. But we usually perform not as I did, inside the bag, which it's not safe.
Yes.
Because you can easily, like the nucleus can, you have to have the right nucleus density. If it's too soft or too hard, it won't work. You have to maintain your foot switch work perfectly, like say, in tune of the rate of the nucleus emulsification you get, so that the nucleus doesn't stop rotating and comes continually. So it's not easy at all. But I usually use this when I perform phaco in the, like say, over the plane of the iris, and very soft nuclei. You just position your phaco tip a little to the side, or not on the safe zone, but a little, let's say, a little to the side, off center, and so that you allow the big nucleus piece to rotate. That's when I use it the most. It's not a routine phaco technique, definitely.
Just for the sake of the PGs, whenever you're doing phaco, and when you're using the phaco power, as NATO very rightly said, you have to get that sweet spot, what I call, on the foot switch.
Yes.
And don't go beyond that.
Yeah.
You just have to get and maintain at that sweet spot, and then things will move.
Yeah.
Anything below or above doesn't work. So that's important.
Yes,
you have to know
thank
your
you.
sweet
You
spot.
brought an important point. This is something that the surgeon, to let's say, to get where the sweet spot is, like the sweet spot, let's say, it's up to when you press the foot switch and things will go in the most efficient way. you start slowly, and you see the nucleus beginning to emulsify, beginning to move. Keep it like that. If you step too much, the nucleus you get chattering, you get too much turbulence, and the efficiency is gone. So there is let's say, a perfect point where things move, and usually the surgeon thinks, I think this is going too slow. No, it is not. It's the best place because you are using too little ultrasound, letting fluidics do the work, and so this is better on an overall term for the eye. Yeah. Okay, let's go to the wedge technique.
I'd ask VOA members, please put in your questions. Okay.
Sweep and spin technique, what are the chances of zonular dialysis?
Yes. The maneuver itself, it is, when you perform it, you would be surprised at how little resistance you feel. It goes like as if you will feel no resistance. The risk of zonular dialysis is if you don't perform the movement as exactly and let's say on the equator path, if you begin to pull the chopper a little to the center, then you risk zonular dialysis. But I think the greatest risk, and that's when I don't recommend the sweep and spin, and I think the nucleus, the regular spin is better, is if the patient is uncooperative, don't do it. Because if a little movement with the head will, you say you're holding the nucleus like hugging the nucleus. So then it is in this occasion that you may have zonular dialysis. But it is surprising when you get the feel, and of course you don't hold the chopper like too tight. You just hold the fingertips and let the path guide the chopper. You just let's say rotate it. It's not like you need to perform all the movement. Rotating the chopper, it gets in the wrong path, and it's something that you must try to understand that, but you can visualize that. So very gently you go. And the sweep, it's more effective if you go the slowest, let's say, as slow as possible. The spin, it doesn't make any difference. I do it fast because I'm used to, but you don't need to perform it fast. It makes no difference. So if you perform, and there is let's say, an important detail on the sweep and spin technique. When you're performing the sweep part, the nucleus should not move. It can't move. You must go, and when you perform it and the nucleus is not moving, you're on the right place. When you come down, like here, subincisional is the most difficult part because you need to move your hand like that. It's difficult to show, but then the tip stays still, and you move like that to be able to continue. And then you begin nucleus rotations. It's like a two-step procedure. You first do the sweep with the nucleus completely still, and then you make it. If the nucleus begins to rotate before, it won't release all cortex. Then you should, like say, perform the regular spin. Come out and perform the regular spin. Yes, I usually refrain from doing the spin, even the sweep and spin in, let's say, zonular dialysis cases, or especially in zonular compromised situations. But any other type of cataract, you can perform it. Of course, in very mature cataracts, you have a problem not with the maneuver, but because in these situations, there is usually very adherent cortex, especially on the posterior capsule or in the, let's say, on the back's periphery, which won't come out with the spin. And so usually they don't come out even when you try to polish. This is very adherent material, and it's usually left. But this is on harder nuclei. I think in harder nuclei, the importance of making the spin diminishes because you already have much less cortex, like a very soft cortex. it's not that more difficult cortex that you get, especially in softer cataracts, that it's sticky to the capsule. Yeah.
You can go on to the next one.
Okay. Okay, so I'm showing the wedge mechanical fracturing technique. This is a phaco technique that I developed to achieve maximum efficiency in soft and medium hardness nuclei. And I use it, of course, in the vast majority of my cases. The wedge chopping is a mechanical fracturing technique, meaning that no vacuum or ultrasound is employed to divide the nucleus. This is an important feature. The nucleus division is achieved by compressing the nucleus piece between the chopper and the phaco tip. Mechanical fracturing, of course, is a well-known phaco technique, and many surgeons use it. So why the name wedge? That refers to a modification I made to the technique. By positioning the tip sideways, its bevel acts like a wedge to initiate and propagate the cracking, cleaving the nucleus fragment while the chopper holds it. So, it is a horizontal chopping technique. A long bend chopper with a blunt tip, similar to the one I saw in the spin, is recommended, usually with a 2 millimeter or bigger bent portion, and a ballpoint for capsule safety. The chopper acts embracing the nucleus equator. Now the important detail. The phaco tip goes sideways to present the bevel as a wedge. 45-degree tips are better suited for this technique. Using irrigation only, the chopper compresses the nucleus material against the phaco tip. The tip's wedge initiates the fracture, which is propagated along the natural cleavage lines of the nucleus. After complete nucleus division, the pieces are routinely emulsified. Let's see the technique. I'll first show the critical details of it, how the fracture is performed. The aspiration and vacuum settings remains at 0 during wedge chopping. No ultrasound or fluids are used to achieve the fracture. The tip goes sideways and the chopper hugs the nucleus, being brought horizontally towards the end of the bevel as the fracture begins and completes in a clean line. This is a crucial difference between wedge and traditional mechanical fracturing techniques. The sideways bevel has the shape of a wedge, as you can see, and it is at the bisector of the bevel angle that the vector compression forces propagate, initiating the fracture. Compressive forces are concentrated in a small area, making the action more effective. That's how the fracture happens. Here, then, is the complete technique. Notice the sideways position of the tip. This is, of course, most important, which appears like a wedge. A long blunt-ended chopper is ideal. The one I use is 2 millimeter in size. Rotating the nucleus, I go completely dividing it in 8 pieces. Although the 4-quadrant division is the most common method. The fracture propagation of the fragments can be seen following the natural cleavage lines of the nucleus. By using the phaco tip's bevel sideways, acting as a wedge, the nucleus is divided using only mechanical forces. No ultrasound or fluidics are employed. Only then do I proceed to pieces emulsification, sequentially, one by one, according to its location. Merits of this highly modular approach become clear as control, safety, and ultrasound usage efficiency are outstanding. What are the advantages of the technique? The wedge chopping is very easy to learn and master, with no need to change the surgeon's machine settings. It can be performed with basic or lesser machines, so to speak, also, associated with other techniques and during pieces emulsification. Nucleus hardness for 1 up to 3 can be approached by the technique, which is the majority of cases for most surgeons. The US power applied in the case is significantly less with the technique, which is important in a general sense, but especially in cases with compromised corneal endothelium, for example. by not using vacuum and ultrasound. Safety is one of the hallmarks of the technique. Efficacy is maximized because the compression forces are applied in a very small area by the tip with easy cracking. This is the biggest difference between the wedge technique and, let's say, traditional mechanical fracturing techniques, where the phaco tip is presented on the front. So we have a large area where to apply forces, and it's not concentrated as in the case of the wedge chopping. The phaco tip stays on the safe zone at all times. The chopper does the most of the manipulation. And as it does not depend on vacuum, it is very fast. I strongly recommend you all to learn and use the wedge chopping mechanical fracturing technique to enhance overall efficiency and safety. It is a valuable technique that can be used in most of your surgeries alone or associated with other techniques. This is another case where the wedge technique is used. Here, performing the sweep and spin, and then going for the wedge mechanical fracturing. Sometimes soft nuclei are the hardest to, let's say, the most difficult to approach, and the wedge chopping technique makes it very easy. So it's, I think it's a valuable technique to learn. And in a few, let's say, I think with a few surgeries, all of you can really learn to perform that. It's not a difficult technique, and at this time, when settings remain at 0, as you can see in the video overlay, now I'm beginning to aspirate. But it's very safe because you have no surge, no risk of capsular rupture during when you're performing the wedge techniques. Of course, this is one of the, let's say, the techniques that I use, but I have many other techniques for soft and hard nuclei. Some of them I just show on the channel just to, let's say, for reasons of education. That's not, let's say, my preferred techniques, but I think that surgeons should learn as many as possible phaco techniques because, of course, you can't approach every nucleus density with just one technique. You should learn and should choose the best technique for each case.
You're showing spin technique in SICS, that one slide. You're showing one slide, spin technique in SICS. You have that video?
Oh, yes, it was. I can get it again. Sorry. I skip it because, well, let's say it took too long. Let me get it. See if...
One of the questions that came is, where do we get the round tip chopper? And I'll answer that. You can get it with, I have given the chopper. NATO has no financial interest. I also don't have financial interest, although I wish I had. But anyway, I don't have any financial interest. So you can get it from Apaswamy. He is manufacturing it. NATO has very kindly given those choppers. So anybody who wants to order can order it from, just ask for the NATO Positeli chopper, and you will get it.
Oh, thank you. So I show the spin. Oh, let me go. Okay, sorry. Yeah, let's start again. I'll show the spin in SICS, which is something that you can do. This is a regular SICS with a conventional trapezoid sclerotunnel. The side port is optional, yeah? And our regular 5.5 millimeter capsular axis is fashioned. After that, the anterior chamber opening is subsequently enlarged. Gentle hydrodissection is done, and then the anterior chamber is again filled with OVD. Then the long blunt chopper enters under the anterior capsule, as you have seen, and slowly traverses the lens equator opposite its entry side before nucleus rotation, separating the cortex from the capsule. And now nucleus rotations begin, both in clockwise and counterclockwise direction. By now, the surgeon can feel that all cortex is detached and carried along with the nucleus. Nucleus prolapse and extraction are routinely performed. The detached cortex and epinucleus remnants are burped out with OVD and washed out with BSS. There is no need to use irrigation aspiration techniques because there is no cortex left upon completion. This makes the surgery much shorter, much quicker, and safer, because usually in SICS you need to get the synco probe to perform aspiration, and sometimes there is much cortex left, and this really makes the surgery much more efficient. Yeah. So the spin is a technique that can be used and should be used both in phaco and also SICS.
Maybe we can use the Sinsky hook in SICS. If people are scared to use
Yes.
the long tip ball chopper,
yes.
the Sinsky hook, you can use it.
If it's a softer cataract, usually you need sometimes a second instrument with a somewhat larger area to be able to rotate it. But you can do it with a Sinsky. Like say, a nucleus 2 plus, or it's easy with the Sinsky, and then you don't need to, to perform the sweep and spin. You just do the regular spin, it's okay. Yeah.
With Sinsky, I don't think we should advise to go to the sweep. Sweep,
Do the sweep with
that's
the
one
Sinsky,
point,
yeah.
please remind, don't try sweep with a Sinsky hook.
Yeah,
Sweep
no,
means
yes,
with only
definitely.
ball,
Yeah.
blunt end only.
Yeah.
Otherwise, you will spin the posterior capsule. That
So,
is a wonderful video. Any complications? Any complications? Videos? Challenging videos?
Oh, I'll bring one. I think it's, I don't know, this is not so much for novice surgeons, but it's like how I began to do the sweep and spin. I'll show the mechanical cortical cleaving for posterior polar cataracts. These are like very challenging cataracts, and what I show here is something of a paradigm shift in managing these cases. And so I think it's interesting to bring. And in this, you will be able to see like a pure mechanical cortical technique being applied with no hydrodissection, okay?
Very hard and black or brown cataracts. What is your approach?
Oh, well, I'm mostly a phaco surgeon. And as that, we always think that we are able to, let's say, approach any nucleus hardness with phaco. But that's not what I do. Usually, in all cases, I try to, even in softer cataracts, I think mechanical, let's say, mechanical chopping, mechanical cracking techniques are more efficient because you use less ultrasound and are usually more safer. That is especially true with very hard cataracts, because when performing mechanical forces to achieve nucleus fracturing, you avoid all the ultrasound, all the nucleus manipulation that you're doing, like if you're doing direct or phaco shock, for example. So these are, and I have three, like say, techniques that I usually employ in harder cataracts. I usually, on not too hard, like the extreme cases, on the hard ones, but not the nigra and so somewhat tube luminescent cataracts, I employed Mohanta's submarine chop, which is very easily incorporated into, I think it's a very easy technique to learn. I think Every surgeon should learn it. It's the one that I use the most, of course. I can safely say that I perform the submarine chop like at least 15 times every day because I get a lot of hard cataracts. The other two techniques that I employ, one is a pre-fracturing using an instrument developed by a fellow Brazilian, which is Sergio Jakobowicz. It is the Jakobowicz chopper. It's a very tiny instrument with front cutting action. And then with that, I hold the nucleus and perform like a nucleus slicing going with the other instrument. I usually divide the nucleus into 8 pieces like that, just under OVD, replacing OVD, rotating. So when I finish, the nucleus is completely divided, including the posterior plaque, which is the most challenging feature in very hard cataracts. And the rest of the surgery is very easy. And the amount of ultrasound that you apply, of course, after that, is just for emulsification. You can use lower fluidic parameters for that, so the surgery is even safer. And the other instrument is used in a similar way, but it is I'm sure that most of you never seen that. I have a video. If you have time, I can get it here. It's the Ultra Chopper. The Ultra Chopper is a phaco tip, but it is not a phaco tip that is used also to emulsify the nucleus. It is used only to cut. You can think of the phaco tip like an electric knife. What you used to to cut, like say turkey or don't know, so it's like that. It is an ultrasound. It has the shape a little like a sickle with slightly bent forward. It has 2.5 millimeters long, and by applying ultrasound, it cuts the nucleus like it was butter.
This is from Alcon, right?
Yes,
Alcon,
let's say, yes, provided that for a few years. It was developed by my friend, Dr. Luis Escaf from Colombia in 2006. But a few years after, Alcon stopped, let's say, selling it because most surgeons were afraid to use it. When you see it, it's somewhat scary, but it's very safe, very, very effective. And now there is a new version of the Ultra Chopper. I just got it. Let's say, it just came home. Dr. Luis Escaf sent to me, and I was not able to use it because I was already here in India. So I'll be uploading videos with it shortly. And these are the three techniques that I intend to perform phaco. But in, let's say, 2 hard cataracts, compromised endothelium, etc. I do SICS, which is very, very safe. And I usually say to my Brazilian friends, unfortunately in Brazil I can say less than 30 surgeons know how to perform SICS. Most of them perform phaco, but the ones that still, let's say, perform many manual cataract surgery, they do it performing ECCE like with a limbo incision, which is horrible. I don't think it should be done. But I try to convince my fellow colleagues in Brazil to learn SICS because it's amazing. And I think, besides, apart from its safety and these characteristics in hard cataracts, with SICS, you are always sure that you will get the job done. Not so with phaco. Sometimes you start and you see that the zonules are not so good, the nucleus is too hard, you're not able to crack the posterior plaque, or sometimes you get a radial tear on the capsule, and so you are working in an unsafe environment and with unsafe conditions. It's not so with SICS. You just do a large tunnel, take the nucleus out easily. So I think really SICS is the way to go. Unfortunately, I'm not that proficient in SICS as my fellow colleagues, especially Sunil. I learned most of what I learned in SICS Sunil taught me. And so I have really to thank him for having taught me, and he's a great mentor of it for me. Thank you, Sunil, for that.
Just for the PGs, Pradeep Mohanta's technique submarine chop is the same principle as the woodcutter's chopping technique of Mahatme. It's the same principles, slight variation. The Yakovitz chopper, if you can imagine, Sohail Khan's chopper, which he has brought out, the Yakovitz chopper is a miniature version. Okay, but Yakovitz was much, I think he patented 8 years ago or something like that.
Yes.
Yakovitz. So it's like that. So for people to have an idea of the...
Yeah. It's a similar concept, and I just got Dr. Sohail's chopper. He kindly brought it to me to the CCC in Hyderabad, so now I'll be shortly uploading videos with Dr. Sohail's chopper also.
Yeah. There's one online question. What is
Okay,
your
of course.
preferred technique for soft cataracts with PSC? But you are anyway going to show that. This is not, you are going to show posterior nodal cataract.
Oh, yes. Let's say, for very, very soft cataracts, I just, let's say, do hydrodissection. I try not to do too much initially because I want to perform a little spin on it. But sometimes it's very soft, you can't. As soon as you begin, it begins to prolapse. And if it prolapses, I just continue doing and then do phaco aspiration with it, like, say, completely on the anterior chamber or partially in the anterior chamber, getting it. In let's say, a little not so soft, I do the mechanical cortical cleaving, which is as easy as this. So it depends on a little on how things go. If the nucleus stays in if the soft nucleus stays in the capsular bag, I do the wedge. If not, I do the simple phaco aspiration.
Yeah. We'll move on to your, this is a very, very interesting talk. It's a paradigm shift. You're talking, for mechanical cleaving. Yeah. Just watch this carefully. This is really, it changes your whole concepts of what you've been taught for the last 20 years.
Okay, I'll present this technique that I developed to approach posterior polar cataracts. The technique is amazingly effective, and I have been using it for some years with great success. A posterior polar cataract is a round, discoid, opaque mass that is composed of malformed or distorted lens fibers located in the central posterior part of the lens. This location is its most significant feature, and in addition to its proximity to and possible adherence with the posterior capsule, this is what most call our attention to it. It is a dominantly inherited disorder with variable expressivity. The incidence is around 3 to 5 in 1,000. I see a lot of them in Brazil. I usually, let's say, get some 10 to 15 cases every month of posterior polar cataracts in my practice. I don't know how the incidence changes too much in India, but I think this is so all over the world. Yeah, same. A posterior polar cataracts are challenging cases due to the often present thinness and fragility of the central posterior capsule. That, along with other abnormalities, demands a different approach than those used in routine cases. Most posterior polar cataracts are operated on at a much younger patient age than usual, and the soft nucleus management might be a difficulty factor for novice surgeons. In the traditional posterior polar cataract approach, cortical cleaving hydrodissection is usually contraindicated because the fluid wave pressure may cause a hydraulic posterior capsule rupture on a weak point. Careful hydrodelineation helps by isolating the central nucleus core and facilitating its removal. But this approach usually has a problem. With no hydrodissection, all cortex and usually a thick epinucleus shell are left, which is laborious to remove, demanding much manipulation. What are the usual traditional recommendations for posterior polar cataracts? No hydrodissection, or if done, only at the edges avoiding crossing the center. Hydrodelineation is beneficial, whereas nucleus rotations are usually contraindicated. Some recommend low irrigation pressure and to work in a relative hypotony. It is crucial to avoid anterior chamber collapse, as this can stretch the posterior capsule and a rupture this may ensue. This is extremely important. Never let the anterior chamber collapse. That's I think this is the most instances that a posterior capsular rupture occur in these cases. Of course, achieving a perfect thoraxis is essential. In posterior polar cataracts with no hydrodissection, a thick adherent cortex epinucleus shell usually remains, posing difficulties and hazards in its management. I therefore developed a technique to release the shell from the capsule in these cases, the mechanical cortical cleaving for posterior polar cataracts. This is a typical appearance of a posterior polar cataract. Please note the central discoid opacity, surrounding vacuoles, and degenerated lens material. Remember, when dealing with posterior polar cataracts, performing a perfectly centered and sized capsular axis is imperative, as it can provide support for a sulcus placed IOL with opt capture as a plan B, should a posterior capsular rent happen. So, what is the mechanical cortical cleaving? I mechanically detach the cortex from the capsular bag using a long blunt chopper. Notice no hydrodissection was done. The chopper traverses the space between the cortex and the capsule 360 degrees around the lens equator. By going from two opposing side parts, access is granted. This is going from the right side. And then I similarly complete the maneuver from the left one. But this time, I'm under irrigation from the phaco probe. After the cleavage is achieved, the nucleus can be safely rotated to make sure all attachments are released. Then routine nucleus management can be performed according to the surgeon's preference, greatly facilitated by the previous steps. In the vast majority of cases, no cortex is left. This technique was created before the sweep and spin. And that's how I got the idea to enhance the spin by doing the sweep in, let's say, at least half of the nucleus. That's why I got into the sweep and spin. Now, I'll show an interesting video demonstrating the safety of the technique. And here, we'll see also how important an adequately performed capsular axis is as an essential asset in complicated cases. Avoiding hydrodissection makes it challenging to deal with the remaining thick and firmly attached cortex epinucleus shell. The mechanical cortical cleaving technique was devised to overcome that. And here, okay, I'm going from the two opposing side parts made, traversing the space between the cortex and the capsule around the lens equator. A chopper with at least 2.5 millimeters is best, ensuring sufficient cortex detachment at the equator. The curved equator capsule deforms to accommodate the straight profile. Now I'm going from the other side, and the lens mass is entirely free, and easy management follows. The soft nucleus in here is approached by mechanical fracturing and emulsification. Any technique can be used, of course, but usually soft nucleus are approached like that or by phaco aspiration. No epinucleus or cortex remain, but the fragile posterior capsule wasn't disturbed by the mechanical cortical cleaving maneuvers. I tried to remove the the opacities in the compromised central posterior capsule, but upon the slightest touch, it opens. So this shows how fragile this capsule was. This was a mistake. We really shouldn't, like say, try to touch the posterior capsule in these cases. But so I converted to the capsular end to the posterior polar, the posterior capsule, capsular axis. But I consider it too wide for a safe in the bag IOL implantation, so I implant a 3-piece IOL in the sulcus. Suturing is done, as I most often do in cases of APCR for safety. And then I am able to perform an IOL optic capture because the capsular axis was centered of an adequate size, and this provides safety because it completely separates the posterior and anterior segments. In these cases, there was no vitreous prolapse because the anterior hyaloid was not disturbed. And so this case shows how the mechanical cortical cleaving technique in PPCs is safe, even in the presence of an extremely fragile posterior capsule. You saw that it withstood all the maneuvers of the technique, no problem. But when I went to try to remove the little opacities, it broke. And it's being like that. So I am, let's say, this is a technique that has given me much ease to deal with these cases with really no concern or no fear of rupturing the posterior capsule. So access is best going from 2 opposing side forts. No hydrodissection is done. Hydrodelineation, although unnecessary in most cases, can be performed if the surgeon wishes so. The long blunt chopper must travel the lens equator all around until nucleus rotations begin. The mechanical cortical cleaving can be performed under OVD or irrigation with the phaco probe. The technique has many advantages. It is very straightforward, and thus it is very reproducible. Complete cortex release is quickly achieved with minimal need for further management, minimizing the risk of capsule rupture in the cortex management step. Also, it can be performed with very low fluidic settings, which is beneficial in the presence of central capsule fragility. And finally, this technique can also be performed, of course, in MS-ICS. The main disadvantage of the technique is that it does require some degree of experience and skill from the surgeon. It's not an easy technique. And so the surgeon must be very, let's say, experienced and comfortable with doing this maneuver because, of course, there is less room for error. The maneuver is not too difficult, but it should be perfectly performed. And I've been using this technique for many years and found it highly effective and safe. I hope you find it helpful. It simplifies posterior polar cataract management. If at first an idea is not absurd, then there is no hope for it. Thank you. Many colleagues see that, and it might look scary. They say, this is crazy. But when they begin to perform, they are amazed at how effective it is. But it's not an easy. So this is really, I think that surgeons should try only after having achieved, let's say, some degree of proficiency and experience.
The most important thing of the talk, especially juniors and even the rest should get, is that please do not hold on to ideas that are 20 years old and not let go. If you actually look at management of posterior polar cataracts, it will tell you, don't rotate, don't hydrodissect, don't do this. This is the traditional way, and we have been holding on to it, and still most surgeons will do it that way. But as Einstein, as the last slide that you put it, you always question, try out. And that's what Dr. Nato, this is a perfect example of letting go of traditional beliefs with no scientific basis, and question. And many of these techniques you can, I mean, I've been performing this technique after seeing Neto. It really works. It's as he says, so very difficult. It's difficult to do it. Yes, it is. Nothing is easy, but it can be done. It can be done.
Thank you, Neto. That was a wonderful lecture, and then wonderful demonstration of the videos of the skill. And once again, thank you very much. Please accept a memento from our side.
Thank you.
State Ophthalmic Society and the local Ophthalmic Association. And it's the global leaders in ophthalmology lecture. First was given by David Chang. You are the second one, and very fortunate to have a second global. And Madhu is instrumental in all these things. He was the scientific committee chairman.
Gopal, most important, without Agda, you couldn't be here. Okay.
So it's a team. I request Agda to please join us. He was always insisting on team and all team. So you have to be here.
Oh, how nice. Thank you. Oh, thank you. I'm so honored to be here, and I really appreciate all your kindness and hospitality and love that you have shown. We are really moved that we really feel at home here, especially here in India, all over, because I think we have many differences between our countries, but I think the people, yes, it's like we are at home and everyone is so kind, and so thank you very much for
Please, all of you join us for a group photograph.
So Korea has to do it again, huh?
I think we can do one. Okay, I'll be down here. Yeah, like a football team. Yeah. I think we'll need to go farther. Yeah, farther. Wow, so many people. Okay.
Thank you.
Dr. Meenakshi from RH.
Dr. Meenakshi madam. So Dr. Neto, we have one gold medal for the best free paper session. So you want you to, madam is a senior most ophthalmologist.
She has sponsored. Can put it.
Next is Dr. A. Anjani.
దానికి ఇచ్చేస్తా.
Both the combined winners, combined joint winners for the medal.
You can also come.
Come, please come.
అటు నుంచి అండి. ఎలా వచ్చి
So next year, please prepare all the other rest of the PGs. Somewhere around February, March, we will conduct. Thank you.
నర్స్తో అనౌన్స్ చేసి విఓఏ ఫ్యామిలీ అని చెప్పాను.
Next, we are moving on to the VOA winners in APOS and midterm AIOS. So the film festival best video goes to Sudhakar Naidu, Laveti. And GRAD best paper conference, Dr. Bhavik Panchal. Professor Vengal Rao best paper goes to Dr. G. Divya. Dr. Vishnuvardhan best anti-segment paper, again Dr. Bhavik Panchal. And Srikiran best poster goes to Dr. Shanti Penmasa. And Gangadhar Reddy PG quiz winners, RIMS Srikakulam. Give them a big hand. So now the meeting is adjourned with a vote of thanks.
Okay, thank you all of you. I think we lost 3 wickets. All of you go back and then support the Indian team. Thank you, Vijay Kumar, for excellent coverage. Thank you.